Okay, so we're going to start. So today we're going to talk about the things that I've learned and then some of the things that I hope to incorporate one day. In the ER, sorry. I'm going to spend some time focusing on and tackling one of my all-time weaknesses in the ER, the dreaded EKG, and sprinkle in some life lessons that I've learned that have helped me during residency that can hopefully be of use to some of you guys as well. This is a really busy outline, but it's basically that we're just going to be going back and forth between some EKG stuff and then some life lessons. I think one of the most intimidating things that I saw during my residency was the constant bombardment of EKGs that attendings get. As I moved towards the end of my residency, the thought of being responsible for this made me feel like my stomach was going to come out of my throat. How would I know if I was missing something? I really wouldn't. But as I asked attendings that I was close with how they managed this intense pressure, many had the same response. They were mostly looking for evidence of occlusion. We know the tried and true STEMI definition of greater than 2.5 millimeters ST elevations in V2 and V3 for men less than 40, greater than 2 for that same area for men greater than 40, and then greater than 1.5 for females in those two leads, and then also greater than 1 millimeter on all other leads. But there are also STEMI equivalents that represent coronary occlusion without meeting traditional ST elevation criteria. In 2021, there was a retrospective case control study out of Stony Brook University in Hennepin County, looking to compare the diagnostic accuracy of Occlusion MI ECG findings versus the formal STEMI criteria to diagnose Occlusion MIs. The study found that NSTEMI, or the STEMI negative population, actually comprised of two different subgroups. STEMI negative Occlusion MI patients who actually have an acute large vessel coronary occlusion and similar outcome, severity to STEMI positive Occlusion MI patients, and then also non-occlusive MI patients, identified by subsequent trope elevation, but not by ECG Occlusion MI findings, who usually need an intervention, but maybe not emergently. Despite the fact that these STEMI negative Occlusion MI patients have a similar angiographic findings, highly elevated troponins, and high risk of pre-cath cardiac arrest or index visit mortality, similar to the STEMI positive Occlusion MI group, these patients were much less likely to receive emergent cath. They concluded that the blinded interpretation using predefined Occlusion MI findings was probably superior to the STEMI criteria for ECG diagnosis. Some of these STEMI negative Occlusion MIs include things that we often memorize, like the winter T waves, Welland syndrome, posterior MIs, ST elevations in AVR, and T wave inversions in ABL. But before we get to these things, let's go back to the basics and really understand why they cause the EKG changes that they do. So I kind of want to go back and really break it down to when we first started medical school, when we talked about this, because I think that during like our second or third year of med school, when we're reading, everyone's reading Dubin's, and it's controversial because the guy's probably messed up, but you go to residency and you kind of learn all these EKG things, and we don't really go back to understand, hey, now that I understand EKGs, how did the information that I learned back then, how does it apply to what I'm doing now? So everyone knows the thumb rule. You know, we often look at leads 1 at AVF to predict access, and it's the expected vector of depolarization of the heart. The normal electrical access usually ranges between -30 and 90, which means that when we average all the vectors, we expect to get the resultant vector within this range. But instead of just using the thumbs, you can also just use this picture to kind of understand, because even though we're only looking at these two, which is the basis of what it mostly is, sometimes it's kind of hard to identify, is this actually upright? Is this kind of equivocal? And you can use some of the other leads as well. The only thing that it's important to note is AVR here, it's negative AVR, so it's actually pointing in this direction right here, but often it's presented this way. So now let's look at this in 3 dimensions. We're going to come back to this picture over and over again, and this I compiled like an anatomy picture with some of the leads that we were seeing in the other pictures. So just to kind of get an idea of where the blood vessels fall in relation to where the heart is, in relation to where the vectors are. So now let's look at which parts of the heart are supplied by which vessels. This can be anatomy specific, but generally the septum is supplied by the diagonal branches of the LAD. The anterior wall of the LV is supplied by the diagonal branches of the LAD. The free wall is supplied by the left circumflex arteries, marginal branches of the LAD. The posterior and inferior left ventricle is supplied by the posterior descending artery, which can either originate from the RCA or the left circumflex. And then the right ventricle is supplied by the marginal branches of the RCA. So when we combine that picture with the three-dimensional heart that we spoke about, we find that we can identify segments of the heart that correlate with specific EKG findings. Seeing this, which is basically like quote unquote normal EKG, we can also see that when we talk about like R wave progression in the septal and lateral leads, it actually correlates to, because if the vector is actually in the direction that we expect it to be, you would expect the R wave to go increasingly more positive deflection. And so when we hear these things, when we think about the actual picture of the heart and the EKG, it correlates more than just like memorizing it and kind of thinking this is what it should look like, but this is why it should look like that. In turn, we can use what coronary arteries parts of this EKG correlate with, which is really important when we identify our typical ST elevation MIs and signs of cardiac ischemia. So now we're going to jump back into enough about the EKGs, more back into the life stuff. Do the things that you find most interesting and you'll find your niche. So going into residency, most of intern year, I felt like I was barely getting by. I saw most of my colleagues doing all these really impressive things, research, getting published, joining all these clubs. And I didn't know what I could do. Was my alcohol tolerance high enough to be part of the sono team? Did I have the endurance for the wilderness team? I didn't even own hiking shoes. But I eventually realized that if you just participate in things that you find interesting, eventually you'll narrow down and see that the things that you gravitate towards are your niche. And that doesn't necessarily mean that that's what you have to go into fellowship. I ended up gravitating towards a lot of the wellness initiatives and procedure days and education stuff. And I ended up going into global health for my fellowship. So the two weren't even really related. And at the time I thought maybe I should be doing a different thing or I should know exactly what I want to do. But it just shows that, you know, go towards the people that you gravitate towards, whether that's attendings or residents that you enjoy being around, and eventually you'll find out what you want to do. Right bundle branch blocks. So we all know the bunny ears, but what do the bunny ears actually mean? Left bundle branch block on EKG in a patient with acute chest pain is often seen as diagnostic criteria for acute MI and generally warrant urgent coronary angiography and cardiac cath. However, the significance of a new right bundle branch without any other acute EKG findings is unclear and currently not really considered a criteria. Although there's no significant association with cardiac risk factors, the presence of a right bundle branch block can be a predictor of mortality and MI, heart failure, and certain heart blocks. In asymptomatic patients, isolated right bundle branch blocks typically don't need any further evaluation. But there are case reports showing that patients with the new right bundle branch block and chest pain who did not undergo reperfusion therapy were ultimately found to have complete coronary occlusion on angiography. That doesn't mean that we should be cathing every single patient with the new right bundle branch block, but we should be able to identify it and consider ACS. So the right bundle branch is supplied by the LAD. So you should consider an LAD occlusion in patients that have a new right bundle branch with chest pain, with or without an left anterior fascicular block. So what's going on with the EKG? Normally, both bundle branches are depolarized at the same time. In a right bundle branch, the signal in the right bundle is delayed compared to the left. So the right ventricle contracts later. So when the right ventricle is contracting later, you kind of see a delay in the R for the right side than the left. And it causes the two QRSs to be out of phase, and it correlates with this widened QRS as well as the RSR that we typically see. When you think about where the right bundle branch is located and what's supplied by the LAD, you can see it kind of falls over where the V1, V2 is, and sometimes you also see it in V3 depending on the person's anatomy. And that's why we kind of tend to see this RSR in V1 and V2. If the QRS is not widened to more than 0.12 seconds, it's considered to be an incomplete right bundle. So you still have a little bit of that block, but not enough to cause a complete delay. It's also important to know that whenever you have abnormal depolarization, it's usually accompanied by abnormal repolarization, which can manifest as ST depression and or T wave inversions in these leads as well. You can kind of see that here in these two. Now let's talk a little bit about the left bundle branch block. So when the heart is depolarizing towards the leads, the QRS complex here will be observed to be upright. If there's a blockage along the pathway, the electrical impulses travel, they need to circumvent the block, and then that may cause a delay. So in the left bundle branch block, the right ventricle depolarizes before the left. The chest electrodes in the left bundle branch are located over the left ventricle. And so the left chest leads like V5 and V6. In left bundle branch blocks, the depolarization of the septum occurs via impulses that spread from the right ventricle, and it slowly goes towards the left ventricle free wall, and the vector is directed towards leftwards. So this is what causes you to have a widened S wave in V1 and V2, and then that broadened, clumsy kind of RSR-ish looking, which is more of a little bit of a slump that we see in these lateral leads in V5 and V6. Though new left bundle branch blocks in the context of chest pain were once considered a STEMI equivalent and part of criteria for thrombolysis, more up-to-date data suggests that the chest pain with new left bundle branch blocks have a little increased risk of acute MI at the time of presentation, and practice is now evolving to examine excessive discordance or concordant ST changes, which is what we consider to be like the Scarbosa criteria, which I'm not going to go over, but we all kind of know that. So just kind of putting these two together, it's just important to remember that the abnormal depolarization also leads to abnormal repolarization. So if you have a positive QRS complex, they're usually followed by negative ST segments and vice versa. So this is what we are seeing in the V1, V2 for the right bundles, and then on the left, and then the V5, V6 that we talked about. Find your confidence. So I think it's fairly normal to have some sort of imposter syndrome when you first start residency. Do I belong here? Do I even know anything? I remember during one of my first months of intern year, I was working at Downstate on a busy overnight shift with Dr. Breville, and Dr. Gore was around, as he often is. I think after a few presentations and overhearing my conversations with the consultants, they approached me and said, Nidhi, you got to decide. Are you going to be a predator or are you going to be prey? And I kind of stuttered back to them quietly, I'm going to be a predator. And then Breville looked at me and said, say it with confidence. So I was like, I'm going to be a motherfucking predator, which I realized out loud probably is not the safest thing to say in a room full of patients. But after they got me this shirt, which I wear every single day under my scrub top, not really, but I think I've realized that it can be really intimidating, especially as someone who doesn't necessarily boast confidence, to find my voice in a profession where people are often so sure of themselves and quick to really turn down someone who maybe shows a sign of weakness. I don't think that I've necessarily changed my demeanor, but I think it's important that whenever you kind of just practice something over and over again and you build your confidence, it's important to be firm and confident in our presentations and conversations while also still being true to ourselves. And that's something that I kind of take to heart today as well, that I kind of have learned, and I'm still working on developing, and I'm probably going to revert back when I become a young attending and we'll have to relearn. Left anterior fascicular blocks. These are probably my least favorite, just in the posterior. A fascicular block involves the anterior or posterior fascicle of the left bundle branch. It's also called a hemiblock. They're usually either the anterior or posterior division of the left bundle branch. Total occlusion of the left anterior descending artery of the left of the LCA may cause a right bundle branch block within the left anterior fascicular block. When you have a left anterior fascicular block, you have a delay in the conduction to the anterior lateral and superior area of the left ventricle. So this causes unopposed depolarization upward, causing left axis deviation. So it's always important to know that with this left anterior fascicular block, you're going to get left axis deviation. On EKG, besides the left axis deviation, you're going to see QR complexes in 1 and AVL, and then RS complexes in 2, 3, and AVF. And so you can kind of see that when you have this left anterior fascicular block here, this is the anterior descending branch of the LCA. And this is where you're having the difficulty of passing the impulse. Make sure you can sleep at night. I always keep this in the back of my mind, whether it's a social situation that a patient's in, whether I'm contemplating a differential diagnosis, deciding whether or not to call psych on a patient that may or may not have told me that they're suicidal. I often find that the patients that I know I'm going to come home and wonder about and worry about are the ones that I like to go back and talk to and consider maybe ordering another test or reassessing to make sure that we're not missing anything. And sometimes that may take an extra moment or some more time, but I think that our patients deserve it, we deserve it, and also, like, you want to leave not thinking and worrying about the stuff that you saw during the day. And I think that as someone who often brings work home, like, that to me is something that I've learned about myself, whether it's having an extra conversation or signing out an extra patient or ordering the dreaded D-dimer on a patient that you just can't explain the shortness of breath for. It's worth it. So we talked about the left anterior fascicular blocks. So the left posterior fascicular blocks, on the other hand, cause a right axis deviation because there's unopposed depolarization towards the right. Alongside the right axis deviation, you can also see a wide S wave in lead 1 and a Q wave in lead 3. And know your limits and ask for help. This took me quite a while to understand, and to this day, when I'm still on shift, an hour or maybe 2 after I was supposed to leave, I often question myself if I'll ever fully embrace setting boundaries and asking for help. But shifts such as CCT have definitely taught me the importance of task sharing that allows for better team productivity and patient care. And just knowing that, sometimes if you have a very difficult patient and you've been working on them for a few hours, it's okay to get a fresh set of eyes or say, hey, like, I'm going to sign this patient out. Maybe you can try to reassess them or talk to them or convince them to stay or try to calm them down. And oftentimes it's not you, it's just the situation where maybe the patient's frustrated at what's been going on and they just need like a fresh face to look at or someone with a different perspective to talk to. Posterior STEMIs. This is an occlusion MI that I definitely will never forget. I remember admitting someone for an NSTEMI my intern year, and when I presented this patient to the MAR, they nicely caught my oversight. Normal depolarization of both the anterior and posterior wall of the left ventricle goes from the inner endocardium to the epicardium. So, however, depolarization of the anterior and posterior wall are in opposite directions of one another. So if you could think you're going from inside the left ventricle outward versus the other way. So while an acute anterior infarct would produce significant Q waves and ST elevations in V1, 2, and 3, posterior MIs produce the exact opposite. So instead of having these large Q waves followed by ST elevation, you see large R waves, which is a positive deflection followed by ST depression. So whenever we see something like this in the anterior leads, or septal leads, sorry, V1, V2, V3, it's important to get a posterior EKG and really consider, are you missing a posterior MI? Eat and take breaks during shift. This is something that I really struggle with, and I apologize to the juniors that we perhaps still haven't set a strong enough precedent. I remember as a junior, I had a senior resident, Jesus, who would force every single junior, even if you were on a shift where there was just one junior resident with one senior resident, which we often had our intern in second year, to leave the clinical area for at least 20 minutes. And if you came back earlier, he would make me turn back around and leave until his clock had finished. It's really important to just find a spot or a table to sit under, cry in, stuff your face, go for a walk. Use that private bathroom that's away from the patient care area, catch golden hour, decompress, and do whatever you need to, but get away from your shift, every single shift. And that moment of clarity will allow you to come back stronger, more refreshed, energized, and maybe happier. So now we're going to come to something that we call STEMI equivalents. Though these may not seem like our typical STEMIs, normal EKGs often have flat or inverted T waves in V1. An upright T wave in V1 should be considered possibly abnormal, especially if it's larger than the T wave in V6. A new upright T wave in V1 is suggestive of acute ischemia of the left circumflex, RCA or LAD, but usually the left circumflex. This upright T wave could signify hyperacute T waves that usually precede acute MI, but you can also see them in left bundle branches, left bundle branch blocks. So just keep in mind, kind of like what we were talking about when we were talking about the progression with going back to the anatomy of the heart. If you're seeing, the larger T wave in V1 than V6 to consider this. Go to breakfast, just go. As a wise attending in the audience here once told me, you'll always be tired. Residency is tiring. You might as well be tired. You might as well, this might be your, and this is when we had 12s, this might be your only social interaction out of work this week. And if you're like Suvam, you can always be tired while you're at breakfast. But you don't want to feel like you missed out on one of these experiences where the entire gang goes out and is doing shots way too late in the afternoon before you have to go back to work, hungover. I mean, that didn't happen ever. T-wave inversions in AVL. T-wave inversions in ST depressions and AVL can be a marker of an evolving MI and possibly RV involvement. Leads 1 and AVL may be the only leads with ST elevation and isolated high lateral STEMI in a diagonal vessel coming off the LAD. So that's when we see them right here. And it can also be an early marker of an inferior wall MI as well. Your co-residents are more than your coworkers. I'm so grateful for my forever glitter Y intern class. They become my confidence, my shoulder to cry on, my go-to for medical and patient care advice, and for a good laugh. I'm pretty sure David's depiction of him holding a patient in the lithotomy position while Hoxine gave someone a rectal disimpaction last night made me laugh for about 30 minutes straight by myself at 1 a.m. Viva la WhatsApp chat. Looking forward to all the advice and out-of-state consults next year when we're all attendings. And the only advice that I've gotten from all the other residencies, from all our residency classes that are above us, is never delete the WhatsApp group. ST elevations in AVR. In the past, ST elevations in AVR was associated with suggestion of left main coronary artery stenosis and triple vessel disease. AVR, like we said before, is electrically opposite to the left-sided leads 1, 2, AVL, and V4 through V6. In the case of subendocardial ischemia, ST elevations in AVR are simply a reciprocal change to the ST depression in the other leads. However, in 2018, a single center study looking at STEMI activations over 4 years at the University of Arizona looked at 99 patients with ST elevations in AVR with multi-lead ST depression. They found that out of the 79 patients that were cathed, only 8 patients were found to have coronary occlusion, to suggest that perhaps routine STEMI activation and ST elevations in AVR for emergent revascularization is not warranted, although urgent rather than emergent catheterization appears important. The study had many limitations and only had a small number of patients and definitely was not a randomized control trial. So I think that further research is probably needed prior to changing practice management, but it's just something to consider. And lastly, life doesn't stop for residency. This includes the memories of events that we choose and those that are unfortunately out of our control. But regardless, remember to take time for yourself and enjoy all the small moments and spend and cherish the time with your life outside of residency. because residency is not for a 4-year hiatus or pause to your life. It's something that we do in conjunction with all the other stuff. And sometimes we have to prioritize the other things, and that's okay. And I just want to take a quick moment, like, not to sound like an Oscars acceptance speech, but just to thank everyone, like all the attendings that I had. I know I've been here for 8 years and I've only really worked and lived in New York. So I really appreciate my experience here. And I'm just emotional because I'm pregnant, I swear. Special thanks to T. Smith, Studs, and Kendall, who convinced me to come to residency here, and all of you guys. And yeah.